So I want to go back to the point at the beginning of what is it that, in a sense, distinguishes CER from sort of your usual clinical research. And I think the point that I really want to emphasize is that it is supposed to provide information to guide choices among treatment options. And so that then puts a slant on the selection of outcomes to focus on information that is relevant in a cost-benefit analysis, not only in terms of dollars and cents, but in terms of what will it cost the participant to engage in this treatment option versus that treatment option, and what will they gain for it, and how does that balance look from their perspective. So the outcomes that we are needing to measure have to be translatable into some kind of practical terms like that for whichever stakeholder is making that decision. And I'm also going to pick up on a theme that we've heard, and particularly John just recently referring to, which is thinking along continua rather than dichotomies. That we can be talking about outcomes at the sort of more proximal or immediate, or what John was describing as sort of the immediate outcome of your treatment and your treatment theory, what it predicts as the outcome, or more distal, less immediate outcomes, which might be those that your enablement model would describe. And often, but not always, going along with this is a movement along a dimension from fairly specific and concrete outcomes to more global or more complex or multifaceted outcomes. And the issue that we grapple with in trying to come up with relevant information is that different stakeholders may be interested in or value different outcomes. So they may be at different points on that continuum. And we've already had some discussions of if somebody's at one point in the continuum, how do we move them along to appreciate something at another end of the continuum? So there are a number of challenges in thinking about the application of comparative effectiveness research concepts to rehabilitation and disability research compared to, for example, the way it was being applied in medicine. One of them is that often proximal or immediate outcomes are more concrete and therefore are easier to measure. So not only is the treatment easier to identify in, say, pharmacological trials, but the sort of immediate outcome that was often of interest was, do you live or die? And that's very concrete, very specific, very straightforward to measure, as are things like days in hospital. If you're somebody on the payer end, and that's a very nice, specific, concrete, very countable piece of data. In acute rehab, we may have, again, some fairly concrete, specific things that are measurable, such as strength, range of motion, or just even very specific tasks that we want to see the person either do or not do before they're released from the hospital, so sit or walk. And for the payers, we've just been talking recently about the immediate cost. How much did those 5 days in the hospital cost? What were the actual charges of that? Those are very immediate, again. We can get them now. And they're very connected in terms of temporal sequence to when the treatment was delivered. However, the goals that ultimately rehabilitation dedicates itself to are more distal and more complex. And those are the ways that often the consumers of services will frame them. And those are, of course, in ICF terms, participation, but even activity is more distal than often the sort of immediate outcome of treatment, or that nice umbrella term, quality of life. So the relevant time period to achieve the more distal and complex outcomes may be long. And that imposes a challenge for us because obviously easier, quicker, immediate, you can add it up soon, you can look at your data quicker, and you can know the outcome sooner. The same goals may be relevant, but additional questions come up. So cost goals are obviously important if you're looking over a longer period of time, but at what point do you stop and tally up the cost? How do you determine when you should be doing that? Which costs should be included? And I think Tony's example was great, and I'm very jealous that you actually had a system within which you could look at all of those different costs, no matter who was delivering them in which clinic, at what time, and so on. And then the question that just came up of, some treatments may show short-term advantage, but no long-term advantage. And over what time period, therefore, do you need to assess in order to determine that? So there are many additional issues that come up in trying to decide what outcome we should be looking at and when. Then the problem that Alan first brought up this morning, the populations we deal with often have a combination of conditions, or they may have multiple sequelae of whatever acute event may have brought them to rehabilitation. I deal with children. They're even more complicated. We've got developmental processes and all kinds of other processes going on. Variations in those combinations may differentially affect responses to alternative treatment options. And as we know, rehabilitation is typically complex with multiple components that may differentially affect outcomes. So how do we incorporate all that into our decision making? So in fact, the selection of outcome measures has multiple things that have to be integrated as we make our choice. First is, who's the primary stakeholder that we're trying to gather these data for? Who do we think needs that information now, or who is going to benefit from the type of information that we're going to collect? What is it that they're primarily concerned with? What is it we are trying to argue with them about, in a sense, or what are we trying to present as a case to them? And what kind of information are they going to find meaningful for that concern? What context will the data be gathered in? And what measures are available? And here, again, we can sort of break it down even more. We need measures that suit the research design. We've talked about differences between an RCT or a pragmatic trial or a observational style. Those potentially are going to involve different types of measures. Measures that capture the relevant outcome, which, as we've just talked about, can vary along quite a long dimension, and therefore we have to determine at what point it's appropriate to capture the outcome. Which ones are suitable to the population, and which are sensitive to change. So I want to talk a little bit more about some of those decisions and how I think that they are specifically relevant in comparative effectiveness research. So to sum up, what, how, who, and when. So first of all, what outcome should be measured to provide useful information if we keep this question of what will help people make a choice? What will help a stakeholder decide among alternative options? And here I'm going to really echo and support John's message of, I think, really spending time on working out our causal model of the processes that are being studied is just absolutely essential. Not only in sort of advancing theory, which we very much need to do, but you can't measure an outcome unless you know what outcome it is you expect. And you can't identify what outcome you expect unless you've really modeled out what's going on in that situation and what therefore is likely to happen. So the mechanisms of action of each treatment, or if we're at the enablement model, I would say even more so, you need to sort of really lay out the broad landscape of what are you doing, what are you thinking it's going to affect, and what other things are playing a role in that, and how is that going to get you to your ultimate outcome. We still need to do more of that. So then, if we've done that, and we sort of feel that we can make a logical case that if we provide this, and this could be very specific, or this could be multifaceted, then we should get that. What measures do we have, and which would be the best match to that outcome? And here, obviously, I've spent a lot of my career sort of trying to provide some better answers to this question, because we haven't always had really good tools to measure the things that we do think we're affecting. One of the things that I think is still being elaborated, the ICF didn't help with its definitions, is how do we classify the different levels of outcome of function and disablement? You know, what is the construct we're trying to measure when we talk about function? How should it be operationalized, and what should we be asking, therefore, in trying to measure it? So somewhat like the treatment theory, I think we also have to have very clear definition in mind of what is that outcome? What is it that we need a measure to capture? And just saying function really doesn't get us very far. we need to then look at whether there are items that are within those measures that really capture our understanding of that construct, whether the measurement dimension is really relevant as a way of capturing that construct, and then again, sensitivity. So, you know, we've had a habit, I think, in this field of once the measure's out there, we're going to use it, and no matter whether it fits or not, because everybody knows it, we'll use it again. And this is not only in adult rehab, I see it with young children as well. You know, a good example that used to drive me crazy was there's an infant test called the Bailey scales. And it, for very young infants, really the only way you used to be able to really look at their cognitive activity was ask them to do something that involved some kind of problem solving or manipulation or something. And from that, you could make inferences about their level of cognitive development. Well, hopefully anybody in this room would listen to that and say, well, then if you've got a child with emerging CP that already looks pretty severe, that's probably not a valid measure to use. And yet people went on and on and on and on using studies because everybody uses the Bailey. And so that's, of course, how we look at the outcome, the developmental outcome of a young child who, you know, and then you name whatever the other condition they're assessing. So we do have measures that are out there, and they do say that they're measuring function or daily activity or community reintegration. But does it really address the relevant domains of behavior and experience that we think the intervention we're providing is in fact going to affect? Do the items make sense to persons receiving either treatment? And I've really been thinking about this a lot recently because I have a colleague, Chris Helfrich, who does research with people who are either homeless or very recently housed with severe mental illness. Well, asking them some questions about management of their home if they're homeless is obviously irrelevant. Hopefully it would be one of the things that would change, but you've already set things up in a negative way if you're asking a person a bunch of questions that make no sense to them, or that are clearly not asking about a domain of experience that's their current focus. And so the items that we assume, you know, well, it says it's function, it must be relevant, we need to look at. And so along those lines, do they sample the activities or experiences that are relevant to the population that we're asking our effectiveness question about? And then a question that, again, I see people ignoring, I think often to the detriment of the study, is the domain measured separately, or is it one of 6 different domains that are all collapsed together into an aggregate score? Which, again, hopefully you realize doesn't make a lot of sense, but I see being done a lot. And then, of course, you've so weakened the ability of the instrument to capture the change in that one domain that you've been targeting that you've kind of undercut yourself from the very beginning. And these are things that are going on right now. And people are doing that perhaps because there is no better alternative, and that, of course, is one of the things we need to keep working on. What I find interesting is that often when we're looking at instruments, people do know to look at the item content, but they often don't look at the measurement dimension. And yet, part of our treatment theory or our enablement theory should really be able to specify what kind of change is it we're actually looking for. For example, do we expect that what we're doing is going to result in a decrease in assistance needed? Is it going to decrease the experience of difficulty, or is there some other aspect of performance that actually is the one that's being targeted by the intervention? That's a rating scale issue, because if your rating scale is measuring change only in terms of amount of assistance, and you're dealing with people who are already living alone in the community, you're not going to find anything that's changing probably. Again, with participation, the question comes up, if I count the frequency with which people engage in certain activities, is that really a meaningful thing that my intervention would be affecting? Am I trying to change the number of times they go to the library, or am I trying to get some other aspect of performance that's changing? For example, the diversity of places that they go in the community, or the distance they travel from their home, for example. So we need to give more thought to just what aspect of change are we really expecting to be affecting? Because the treatment may affect one and not the other. Another challenge is then to make sure that our measurement scale is going to match the degrees of difference that we expect in the population we see. And our measures are often targeted for certain kind of places on the continuum of function. So, some of our measures are targeted for people who are in an inpatient facility, are functioning at the moment at a fairly low level. They're great for that, but with more and more being looked at in terms of people moving into the community, do we have an equivalent measure or a better measure that would capture degrees of variation in that setting as opposed to the inpatient setting? So this is partly an issue of floor or ceiling, but it may also be an issue of simply just not matching in terms of the content of the items, not being the kinds of things that people are doing typically when they're in that environment. I've had a number of experiences that have reminded me of the importance of the wording of items because they don't match what the population I'm intending to see or use to characterize their experience. So an item that says, since your injury, for example, may be very confusing to somebody who's receiving services after a hip replacement, which was not brought about by an injury, but perhaps by some other condition that made them make that decision. Critical question in all clinical trials, of course, is whether the instrument is likely to capture real change if it occurs. And this, of course, is what we get referred to as sensitivity, or the indicator of the instrument's ability to detect change. And these are several of the ways that we are used to looking at that. Even the issue of sensitivity has to be looked at a little bit more critically, however, because sensitivity is usually evaluated in relation to a time period. And the question is, does that time period match the period of our study? If it's sensitive over 4 months, but we're looking over 3 weeks, that may be an issue. Will there be enough variability in the population? In other words, is our sample diverse enough in the quality that we're trying to measure that we're not going to have restriction of range? And this has been a problem in several studies that I've seen because the wording of the items, or particularly the rating scale, didn't have enough degrees of variation to really distinguish things that we were interested in. A critical question that I think CER has really brought forward more than I've seen in the literature previous to now is the possibility of negative outcomes. That not only do we need to look at which intervention is more effective, but we also need to consider the possibility that there could be negative consequences. And have we included in our design a way of measuring that or of capturing that? It could be that we could be looking for changes such as secondary conditions, but we also could have to deal with the possibility that some people will get worse and incorporate that into our analytic plan, because we often assume when we deliver intervention everybody's going to get better, but life happens, that doesn't always occur. And have we checked to make sure that negative outcomes have been examined? Often for the client, the weighing of negative outcomes against the relative positive ones is what they're going to need to do to make a decision. So have we documented those? Have we incorporated that thinking into our selection of outcome measures? And then finally, you all know that a significant difference may have limited clinical significance. And so the question is, do we have any information on a given outcome measure of its, first of all, the degree of change that would represent real-world meaningful difference? Now, this brings up an interesting question. Real-world meaningful difference to whom? And how do we go about determining what is real difference? And I think this is an interesting area where we probably need to do more work. There has been some work that's gone on not typically by rehabilitation researchers themselves, of what would matter most to you, this or that, or various combinations of things. We've heard that the populations we work with are often complex. They typically will have more than one clinical problem. They may also have multiple manifestations of the same problem. How are they going to weigh or weight the different possible outcomes of different interventions? And have we investigated what they would tell us in terms of the relative balance or importance of one thing over the other? So, how important is it to you to be able to get out of the house versus having reduced pain? Or how important is it for you to be able to drive your car versus do some other functional activity? Those are the kinds of things that at an individual level, people are going to incorporate into their decision among treatment options, because it relates to their life goals, their important life activities, and which settings are most important to them to participate in. And I think we really probably need a lot more information than we have about that. So, there's this sort of general rule, 10 points of change in this is enough to make a meaningful difference. Well, when you really look at that, a lot of times what it means is it's enough change to actually see something different about the person, but it doesn't really tell us whether the person thinks, going from this level of assistance to that level of assistance really matters to me. Or it's really worth it to me to go through X procedure, or to invest X amount of time in therapy appointments to get to that point. Particularly when people are receiving services in the community, and going for intensive treatment requires getting to the place, dealing with scheduling, dealing with all the complications that come up. Those are all things that now interfere with other parts of life. How much are people willing to do that in order to get that outcome? Is it enough? Is that change enough that they're willing to do that? And so again, I think that's an area of research that we probably need to attend more to. Who will be providing the outcome information? One of the things that was was a little obvious in discussing the different approaches to treatment studies is the fact that often, depending on the type of study you're doing, you're actually relying on different sources of information. If we're dealing with a treatment that definitely involves an immediate change in performance, there may be one type of measure that we need. Increasingly, though, agencies are asking for information on client or patient-reported outcomes. And so in that context, we're going to need measures that will allow us to gather the information from the person themselves. Or we may need to rely on a proxy. Again, I deal with children, so often I'm getting parent report. Another major source in the kinds of studies we're talking about today is administrative records, where the outcome of interest is cost or therapist time or days in hospital or things like that. So there are a variety of types of assessment, and they have different demands in terms of the resources that is going to be required, A, to get them, or two, to get them with good quality control. And how much you need that's going to depend on the kind of trial that you're running. When should the outcomes be measured? This is, again, where I feel we have to go back to our treatment or enablement theory. What does our theory say in terms of when we should expect to see an outcome of that kind? Is this something that, when it's implemented, you should see the outcome fairly immediately? Or is this something that you expect, according to your theory, that you're going to need a certain amount of practice or repeated instruction before you should start to see the outcome? And if you're dealing with an enablement framework, over what time period do you think you're going to need to wait to see the movement from approved activity performance to, for example, return to work? What is that time period within which we should be measuring? What is the expected trajectory of change plays a role in that. Particularly complicated is the situation where we're dealing with a condition that it fluctuates. so MS, for example, but also conditions where change may occur rapidly. So for a certain period of time, we need to measure fairly quickly, but then there may be a more extended period of time, and over what period should we be looking at? This is where funding becomes an issue, because with those more distal outcomes, we really maybe should be talking a year out to get a full picture of, has the person returned to their previous level of function, for example, if it's been a joint replacement. And then, of course, does this time measure, the time frame that we've established, does that fit with the measure that we're using? So I sort of tried to summarize the thought process that I would say we need to go through, which is really much more of a complex one than even I realized when I started out in this field, probably, of going through a checking process before we end up at selection of the outcome measure. And what I want to call attention to here is there's nothing up here about your standard reliability and validity. That's a given. This is all on top of all of that. And essentially the message is we can't just stop with your standard reliability and validity assessment. There's so much more that has to go into, in fact, having the outcome that's appropriate to measure for the question that we're asking and that our theory supports. So I think that the choice of measure, like the design, is a really key factor in determining the ultimate value of the effectiveness study. If we haven't asked about the right outcome, we haven't really answered our question. We've compared our two interventions, but on something that in fact isn't giving us the answer that we need to help guide choices. And as I just said, that making the right choice really means going quite far beyond what we would see as standard recommendations for how to evaluate an instrument. We're really talking more about selecting the instrument that best matches your purpose and your design. And that ultimately, we need to be sure that the measure will yield information that's going to be helpful to at least one stakeholder, and always good if you can cover more than one base, in choosing among the treatment options. And that is a very quick walk through outcome measures.